Thank you so much for coming out bright and early on what's turning out to be a beautiful Saturday. This is our VHL conference. So without further ado, I'm very pleased to announce Jeff Bruce is an incredibly talented neurosurgeon. Some of you know him personally from taking care of you, and we're just incredibly grateful that he was able to make time to join us this morning. Thanks, Bruce.
Thank you. It's a pleasure to be here. I'd like to thank Dr. Chung and the Cancer Genetics group here and the VHL Alliance for putting this together. And it's a terrific group and have done some great things over the years, so happy to be here. I'm a neurosurgeon here, and I'm going to be talking about central nervous system tumors in the VHL syndrome. Everybody in this room knows that VHL is caused by a mutation in the VHL tumor suppressor gene. And as a result, these genes are passed on to future generations. And the tumors can develop in the CNS, CNS means the central nervous system. That means brain or spinal cord, as well as other organs in the body, particularly the pancreas, the kidneys, and the adrenal glands. And you'll hear more about that this morning by the experts in that area. In the central nervous system, there are two types of tumors that we generally see. One is hemangioblastomas, and usually when they occur in VHL, there's usually more than one. The other is a very rare type of tumor found almost only in VHL patients, and that is endolymphatic sac tumors. And I'll talk a little bit about each of these. Hemangioblastomas, which is the more common type of tumor we see, occur in about 80% of patients with VHL. These are benign tumors. They're actually, if you look at them under a microscope, they look like little tangles of blood vessels. They're very vascular. They have a very rich blood supply, and they're like a tangle of blood vessels that grow as a tumor. They're mostly found in a part of the brain called the cerebellum, which is in the back of the head, and to a nearly equal degree in the spinal cord. About 5% are found in the brainstem. How do we make a diagnosis of this? Well, usually the patients will present with some symptoms, which I'll talk about. And normally an MRI scan of the head or the spine is the best way to make that diagnosis. If you have VHL, it often involves a screening of the chest and abdomen, then of course the genetic testing. Principles of treatment. So when you have a hemangioblastoma, we really only treat them if they're symptomatic. These are benign tumors. They grow slowly. And if you are going to treat it, the best way is with surgery, where you actually try to remove the entire tumor. I'll show you some pictures, but these tumors, because they're benign, they grow as this clump of blood vessels, I said, and removing them, it's like taking out a grape from a bowl of Jell-O. They shell out very easily, and that's why patients generally do very well with this kind of surgery. So what is a brain tumor? We often hear this. What does it actually mean to have a brain tumor, to be a brain tumor? What are they actually made of? Why do they grow? This is a picture of a brain tumor on a histology slide. It's under a microscope. Here you can see this is normal brain here. You see how it's kind of nice, neatly ordered? And this is the tumor. You can see the cells are all different size. It's kind of a crazy growth, but you can see this division between the tumor and the brain. And those tumors are made up of tumor cells. Each of those little things is a tumor cell. So how do cells normally grow? Well, you've heard that VHL is a genetic disease made from genes. Well, every cell in your body, every normal cell in your body has genes. And the genes are made up of DNA. And these genes are passed on to every generation. They're in every cell in your body. And essentially, they contain the instructions to tell that cell what to do. Tell that cell whether it should grow, whether it should stop growing, whether it should turn into a muscle cell, whether it should turn into a brain cell. And all the billions and billions of cells in your body have all this DNA material in it. And the DNA is found in the center of the cell, which is called the nucleus. And we've really developed a lot of tools over the last couple of decades to begin to really analyze what these genes mean. And of course, in a syndrome like VHL, genes are critical. They're very important for understanding the disease and how best to treat it. So in normal development, when right from the time of conception, when the sperm and the egg get together, when we won't have to get into too much of the detail. We won't turn this into a sex ed class, but at the beginning you have the fertilized egg, and the genetic material from the egg and the sperm come together, and that then contains all the DNA, all of the materials for growth to turn that into an active human being. So that contains the material to become from an embryo to a fetus to an adult, and then full-grown adult as time goes on. All of this is encoded in your genetic makeup. All of this is in your DNA. Normally, growth is controlled. You have some signals that come from your DNA that the green light tell the cell to grow. Others give a yellow light to tell the cells to slow down, and then you get the DNA that tells the cells to stop growing. If you didn't have the stop signals, your arm would just keep growing indefinitely. We would be walking around with huge arms and huge legs, but as an adult, you essentially mostly stop growing for the most part. And it's because that DNA, that genetic material, has made the right indications to grow, slow down, or to stop growing. Well, in a tumor, when you have a tumor, particularly when one of these genes or one of these instructions gets mutated or messed up, you stop having the normal signals, and instead of having the signals to slow down and stop, all you get are signals to say keep growing. And so that's what happens. Those tumor cells never get the signal to stop growing, and they just keep growing and growing. And they just, as they multiply, you can see here's a tumor in the brain. Just when it starts at an early stage, over time it just gets bigger and bigger because the cells just keep growing, and this mass just keeps getting bigger and bigger. And that's what happens with hemangioblastomas. The other thing about hemangioblastomas is, in addition to growing and putting pressure in the brain, the tumors actually secrete some substances into the brain that cause swelling in the brain. These same signals that tell the cell to grow are also affecting the blood vessels in the brain, so they become leaky. They leak fluid, and that fluid accumulates in the brain. So not only do patients get problems from the tumor growing, but also the swelling around it. And that can be alleviated with some steroids, or obviously when you remove the tumor, that will go away. So what is it about hemangioblastomas? Just like in real estate, it's all about the location, right? You can take a little townhouse in the Midwest, and it sells for about $600,000. You put that same townhouse in San Francisco, and it's going to cost you $5 million. Same with the brain. Certain parts of the brain are much more critical than others. And if you look at hemangioblastomas, this is what a normal human brain looks like. And this is the temporal lobe, the frontal lobe, the parietal lobe at top, occipital lobe. This is the cerebellum, which is right in the back of the head. This is where a lot of these hemangioblastomas grow. Here's the brainstem coming off the bottom of the brain, also a site for hemangioblastomas. And then the spinal cord going way down the back. Those are the areas where we mostly see hemangioblastomas. So the cerebellum, when you get tumors in the cerebellum, again, here's the cerebellum here, which is right at the back of your head. This is the part of the brain that's involved with coordination. So if you have a tumor here, you're going to have problems with your fine movements, particularly maybe sometimes writing, doing fine movements with your hand. Difficulty walking, your balance will be off. You can get some tremors, shaking in your hands or in feet. Dizziness or vertigo, slurred speech. When you try to talk, your words are slurred. And you also have an inability to make rapid movements. So this is all part of the cerebellum. Here you can see this is a patient with a this black area is a big cyst. It's basically a big bubble of fluid that was caused by this little nodule here. And this is the tumor. This little white area is the tumor. This big bubble is all the fluid that has accumulated because of the tumor. And this is the cerebellum back here. And so just kind of a brief overview. It's about a 7-year training period to learn how to take these tumors out, but we only got about a minute here, and I'll try and tell you how we do this. But you can see this picture. This picture at the top is from the back of the head, where you basically open the skull. You can see once you've opened the dura, which is a membrane overlying the brain, you see the cerebellum, and you can see the tumor up there, which again is like this little nodule of bright red tumor, because it's bright red because it has all this blood supply. It looks like a little cherry. And you can see it in the brain. It's usually in or near the surface. And basically, as I showed you before from that picture of the grape and jello, you can basically remove these almost as a single entity. And you're left with a little cavity there that'll eventually fill up with fluid. Tumors in the brainstem are a little more tricky because the brainstem, talking about that high-priced real estate, brainstem's a really tricky area because a lot of very important functions there. When you have a tumor in your brainstem, you can have difficulty swallowing, also difficulty with balance. You can get dizziness, nausea, and sometimes get even things like sleeping difficulties, where you have sleep apnea, where you stop breathing during your sleep, or insomnia, where you just don't feel like sleeping. Here's a patient with a tumor in the brainstem. So this is the cerebellum. This is all the brainstem here. You can see another nodule of tumor with the cyst in the brainstem here. This patient actually had other tumors, and not uncommon with VHL, where you have more than one tumor. The spinal cord is the other area where we see these tumors. And when you have a tumor in the spinal cord goes from the bottom of your head all the way down your back, provides all the nerves to your arms and legs. And if you have a tumor in your spinal cord, you can get numbness, you get weakness in any of your arms or legs. Also difficulty with balance, because if you're weak, it's hard to maintain your balance. You can get pain. Usually it's not a common finding, interestingly. And you can get increased reflexes. Your reflexes, you touch your reflexes, they move much more quickly. In the spinal cord, these tumors are, the spinal cord is a very thin part of the central nervous system. It's not much bigger than your thumb, and when you have a tumor in there, it can sort of take up the whole spinal cord. And this is actually what it looks like from my colleague, Dr. McCormick, is one of the world's experts on spinal cord tumors. This is the spinal cord here, going up and down, and here's the tumor. You can see that rich blood supply. And here's what it looks like on a diagram. These are sort of an artistic rendering of it so you can appreciate it better. There you can see the tumor at the top and how it's got that robust blood supply. And then after the tumor is removed, you can see what the spinal cord looks like underneath it. Okay, so that's hemangioblastomas. I'm going to finish up by talking about these other rare tumors called endolymphatic sac tumors. And endolymphatic sac tumors are located in the temporal bone, which is the bone right next to your ear. If you were to open up behind your ear, that's your temporal bone. That's where all of your hearing apparatus is, the part of your brain that allows you to hear. That's also the part of your brain that controls your balance. And these tumors are very rare, but when they grow in that area where your hearing apparatus is. So they present with hearing loss or tinnitus, where you get a ringing in your ear, also loss of balance or vertigo. And because the nerve that moves your face goes right along there, if you have a tumor growing there, you can get a facial weakness, what we call a Bell's palsy. Here you can see, this is from a journal article that from the NIH, where you can see this is a patient that had a little bit of tinnitus, and that's actually a normal scan. 2 years later, she still had the tinnitus, and you see where that little arrow is. You see this little dot, literally smaller than the size of a pea, where there was some bleeding. Then you can see over time, a year later, where this actually gets a little bit bigger, And this is a close-up of the temporal bone. There's a little tumor there. Again, not much bigger than a pea, but as it grew, it actually began to cause hearing loss. So it doesn't take much in that location to affect your hearing and your balance. This is what it looks like on a diagram. Here's a bigger tumor. Here's the patient's ear. Here's the tumor. Here's the brain here, and the nerve that goes to your hearing comes right through that. Here you can see on a sort of a diagram, a little hard to understand, but the nerve to your hearing, the hearing apparatus, here's the endolymphatic sac, and these tumors grow right here, right in the center where all of the hearing takes place. So the treatment for endolymphatic sac tumors can be either surgery, where the tumor is removed, or something called radiosurgery, gamma knife, which is a type of focused radiation. Here's our gamma knife suite here at Columbia. And with a gamma knife, you come in, your head gets put in a metal frame so it can't move. You then get an MRI scan, and then using a computer program, we use the MRI scan to direct where the radiation is going to go. So you get a very high dose of the radiation in the machine, but it's given with pinpoint accuracy right to that little spot around the hearing apparatus. So it's a good treatment for those people who are not good candidates for surgery. So let me just finish up by just some general advice about understanding the disease. You all are dealing with here, this cartoon. Is there a doctor in the house affiliated with this person's HMO? Well, you know you're dealing with very specialized diseases, and one of the big problems is sort of getting your insurance companies to sort of cooperate, because when you have these problems, they really need to be taken care of by people who have experience. And just some practical advice, obviously seeking a specialist. You know, when you go to see your doctor, write down questions. Have them ahead of time so you're not fumbling. You know, it seems like you're waiting and waiting. All of a sudden you get in to see the doctor and you forget everything you were going to ask. Make sure your instructions are understood. Sometimes helpful to have a family member with you to make sure everybody understands that you're all on the same page and understanding. Be skeptical of anecdotes. Everybody, I think these support groups are great, but sometimes you have people say, well, so-and-so did this or so-and-so did that. It may not always be relevant to your particular tumor or your particular problem. Second opinions are also reasonable, especially when you have difficult decisions to make about treatment or prognosis. So in the long run, the prognosis, things to keep in mind about VHL in the central nervous system. We want careful monitoring of asymptomatic tumors. Again, just because you have a tumor, it needs to be monitored closely, but doesn't necessarily mean it needs to be treated. So you want to avoid unnecessary surgeries. Sometimes the decision to not have surgery is more important than the decision to have one. Also, judicious use of surgery can maintain a high quality of life in most patients, and that is, if you need surgery, the surgical results are excellent. The long-term prognosis is excellent from these surgeries as well. So having realistic expectations, multidisciplinary approach, that's sort of our buzzword here, is making sure we get all the right people involved to treat the whole syndrome. Keep in mind the natural history of the disease. Again, not everything needs to be treated. And the important point is that surgery is safe and effective, but only for those patients that need it. And the role of radiosurgery is not clear. It's sort of a newer treatment. It doesn't have the same long-term follow-up that surgery does, but certainly in the short run, it seems to be a very good treatment modality. I just want to acknowledge some of the people in the Bartoli Brain Tumor Laboratory doing a lot of the work on genomics and genetics of all kinds of brain tumors. And I thank you for your attention.
So I think in the interest of Dr. Bruce's time, we'll take questions specifically around any of the neurosurgical issues, and if you can say, that's great, but if not, that way we'll get a chance to answer your questions.
Yes.
How accurate are scans? Hi, I'm Jennifer Gallenkamp. My son has VHL. How accurate are, assuming the scans are read by someone that knows they're looking for VHL, hemangios, and things like that, how accurate can you be can you be sure that MRIs are and CT scans? Because just the question is largely because when you see the symptoms, every time my son has a headache or feels a little bit dizzy, I'm like, oh my gosh, you have a brain tumor, even though he's had plenty of scans.
Right. No, that's exactly it. When you have this every little hiccup or every little pain in any part of your body, you think you have a brain tumor. Well, and the first thing is these tumors don't normally grow that quickly, so it'd be rare that that you wouldn't have time to, just at the first sign that there's a problem, you don't have to jump and get a scan. But to answer your question, MRI scans are very accurate. The quality of MRI scans these days, as you see, just to some of the pictures I showed you, we can see tumor 1 millimeter or 2 millimeters in size way before it's going to become symptomatic. So they're very accurate. Yes.
I've had 4 brain surgeries, all cerebellum. At what point is there enough, because you showed the picture where you take the tumor out and there's the hole that fills in with fluid. But at what point do you have enough surgeries where that now compromises the long-term health, your balance, your coordination?
Right. So probably every surgery takes a little bit out of you, but the idea is to do the surgery in the way to minimize that. The nice thing, the fortunate thing about the cerebellum, it's actually one of those areas in the brain that has a lot of overlap. And so if you affect one area of the cerebellum, over time, the other parts of the cerebellum will often take over that function. So at first, you may have a little difficulty moving your hands or your finger, but over time, the rest of the cerebellum will make up for that. And most of these tumors, because they grow as sort of a separate thing. Again, the grape and the jello is the sort of the example. You can remove these tumors with a minimal amount of damage to the brain. And there's, if you have enough surgeries, of course, you may have a certain amount of impairment. But the fact that you've had 4 surgeries and look like you're doing terrific, I think is sort of an example of that. Because of that, though, again, we try and minimize the surgery. When I have a patient with multiple hemangioblastomas, we basically watch it as long as possible. Even sometimes when they have some symptoms, we say, let's put this off for another year, so that we're trying to get them not only through the next year or two, but through the next 20 or 30 years, whatever their natural lifetime is. And in my opinion, if we can minimize the number of surgeries, we're better. Because, yeah, each one takes a little bit out of you, but the idea is that there's no real limit. There's no ceiling on how many of these surgeries you can actually do. Yes?
You mentioned the endolymphatic sac tumors. Is Bell's palsy a symptom of it, or the symptoms are like Bell's palsy?
Well, Bell's palsy is just a weakness in the face for whatever reason. So if a Bell's palsy could be from an endolymphatic sac tumor, but it could also be from a variety of other diseases and tumors. Yes?
My husband and my son both have VHL. My son is 4. My husband recently had cerebellum surgery, but I know with VHL there's screening ages, and you start young with certain screenings. But is there like an age where you see most, like the central nervous system start to develop tumors?
These tumors normally develop later in the teens, so I don't know. Wendy, what did the...
I'm going to give you guys a table later that'll show you when the earliest is that we see symptoms and what the average is.
Okay.
And we'll make sure everyone has a copy of the table afterwards too.
One last question. And how fast do you see technology changing?
How fast do I see?
Technology changing, meaning you'll be able to tell the story about you can have infinite number of surgeries now.
Yeah.
But 20 years ago was not the case.
Yeah.
So how fast do you see it changing? And
Yeah, I think the technology for surgery is not changing much, because the surgery is still a very physical thing, physically removing a tumor. The advances in surgery were made by things like the microscope and advances in being able to minimally, we call minimally invasive surgery, where we minimize how much disruption there is to the brain. I don't know if that's going to change very much. Probably, if there's going to be any changes in the technology, one is things like the radiosurgery gamma knife, which gamma knife's been around for about 30, 40 years, but it's being used more frequently now and with better understanding of the long-term results. And that technology is pretty well developed. Probably there are areas that may be the new technology. These tumors are not, right now there's no medication that works. There's no equivalent of chemotherapy, and it's possible there may be, if there are advances, they may be something along the medical lines. But I will say, yeah, technology is always changing, but I think right now, at least for the central nervous system portion, we have pretty good treatments, and the treatments work quite well.
We have one more question.
How common are pituitary tumors in VHL? And does the normal normal MRI cover that area, or we need a special
Pituitary tumors?
Right.
Yeah. For whatever reason, hemangioblastomas are rare. In fact, in 30 years, I've only seen one hemangioblastoma in the pituitary gland. Just they don't occur there. I'm sorry? Well, the pituitary gland is right next to the optic nerve. So if you have a tumor in the pituitary gland, it often will involve the optic nerves, and you can begin to lose your vision. But fortunately, hemangioblastomas and VHL, we rarely see them in the pituitary gland. Are they hemangioblastomas, or could they be other types of tumors? Could they be normal pituitary adenomas? Which pituitary adenomas are a very common tumor, and it may be that it's not hemangioblastoma.
Okay.
Do you need a special scan, or normally the MRI will cover that area also?
MRI scans are good for that.
Okay, thank you.
Okay, very good. Thank you, Dr. Bruce.